Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Unlocking the Power of Hybrid Service Delivery. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode. If you have questions, please send them to the presenter by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted throughout the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center and onto our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registration remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note the evaluation will close midnight Friday, April 28th. Up to 2 general continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, you needed to include your Florida license numbers when you registered for this webinar. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And now I'd like to welcome our presenter, Sandnes Boulanger, currently serves as the Operation PAR Vice President of Clinical Services, providing clinical oversight to adult and adolescent outpatient access center care coordination. She also has 25 years of experience working in residential and outpatient behavioral health settings, providing substance abuse co-occurring therapy to adults and adolescents via face-to-face and telehealth sessions. She has facilitated online and live telehealth training locally and nationally. She has earned a Master's of Social Work degree from the University of South Florida and a Bachelor of Science degree in Psychology and Child Development, Family Relations minor from Western Carolina University. And now I will turn the presentation over to you, Sandnes.
Thank you so much, Rebecca. You did a fantastic job with my name. It is a difficult one, so that's much appreciated. And welcome to you all. It's wonderful to be here this morning and discussing one of my favorite topics that I've been discussing some time at my organization, and be able to have this time with you to discuss where we are now following COVID with our telebehavioral health and hybrid service delivery. So today, we're going to look at, we're going to develop an understanding of best practices for telehealth services, acquire practical strategies to overcome barriers and challenges associated with the hybrid service delivery model for high quality services, and explore the legal and ethical considerations of a hybrid model of care, allowing practitioners to navigate this complex landscape with confidence and insight. So I saw some people had started putting where they are in Florida. That's wonderful. I'd love to see where people are currently. And I wanted to ask a question that while I start this presentation that maybe you can think about and put into the chat. How many of you are currently using a hybrid model of service delivery? And you can just put yes or no to that. And then also include a number, 1 to 10. And I'm asking specifically how your workforce, if you do provide it, how your workforce, your practitioners feel about it. 1 to 10. 1, they don't care for it at all. It's very difficult. They're not really into it. Or 10, they love it, and this is the best way to provide services for folks. So if you want to go ahead and certainly not everybody has to answer, but just see where people are. Okay, yeah, I see yeses and nos, and I see yeses ranging from 7s to 9s, 4s, 8s. Perfect, perfect. All right, and there's a lot of people that aren't. Okay, all right, so I see a variety of things going on there. That's wonderful. That will be helpful as we go through. So PAR has been providing, let me tell you about Operation PAR first. Operation PAR is where I work, and we are a primary substance use, but we also treat co-occurring facility. We have just under 500 employees. We're in 7 counties on the west coast of Florida. And we have been providing, we have the continuum of care from intervention, prevention, outpatient, detox, opioid treatment clinics. We have residentials for adolescents and adults. We have the continuum. It's case management as well. And we started off with telehealth when I began at Operation PAR 11 years ago. And we were doing what was called Dads at DeMillie. It was a project where we worked with dads that were in prison and preparing to re-enter society. And it was about working with their family systems to develop those relationships so that when they re-entered their family, they could have a greater chance of success. And they did that through video conferencing from the prison, and then the provider was at our facility, and it started there, and that was 11 years ago. And since then, we've done a variety of telebehavioral health ways of working with folks, and we continue to do so now. What happened is we were doing some, but not a ton. I saw some people say we're doing some, where whatnot. And that's where we were. Our outpatient services certainly offer telehealth. Not a lot of people were actually doing it. And so when we were doing that, COVID comes. And all of a sudden, as everyone else experienced, we needed to provide the majority of our services through telehealth and figure out a way to do it. And so we said, oh my gosh, how are we going to do groups? We've never even done virtual groups. The only virtual we had done was individuals. We needed a new safety checklist. We had created a checklist for individual services and from folks working from the office. We recognized we needed a group safety checklist. We needed a checklist for people that are working from home, providing services to people in their homes. How are we going to do drug screens? We had talked about that a little before, and we had a little practice with it, but we were throwing that up. What are we going to do with that? In our residential programs, we needed to social distance, and we needed 10 or less people in a room. So therefore, we had these hybrid groups within a hybrid where there was somebody conducting the group. They may be on site, they may be off site. We may have some people in the room. We may have some people sitting in other parts of the program on a computer or on a tablet. We needed to switch all visitation to video conferencing, and we needed more tablets for our residential program because that was one of the ways that we provide services with our tablets. So when COVID hit, while we had already had our foot in the water, it did present a lot of things that were needed to be added, and we did all of those things, and I will go into that a little bit further. So coming out of COVID, and now where we are, we do provide a hybrid service array. And what I mean by that is when I say hybrid service array that we provide, it is both in office or virtual sessions or assessments or check-ins or fill in the blank. where the provider can either be here on site, as you see the picture of somebody's office here, they can provide on-site services, or they're providing these services from their home. And you see we have a group room here where people can come in. We have live groups. We also have virtual groups. So outpatient is truly our most hybrid program where both the provider and the client, it's kind of a parallel process there, are both either in home or in office or off-site and in office, which is new for us. And we had to come up with some discussion around that. What we currently require is we require outpatient therapists to come in a minimum of 2 days a week. They can work from home 3 days a week. Some people work a 4-day work week, so it would be half and half. However that works out. We require everybody to be here on Tuesdays. And one of the reasons that we require people to come in is as we started having people come back to the office, we didn't have a requirement. And our outpatient therapists, many of them decided to stay home, not come into the office. A few of them wanted to be in the office. They liked it better in the office than being at home. So we had, I think it was about 3 folks that consistently came into the office every day. What started to happen was those folks that were practicing from home would start calling the people in the office and say, hey, can you print this and hand this to the client? They're coming in to pick it up this afternoon. Or, hey, there's extra drug screens coming in today. Can you pick that up and do you mind doing that? And the people that were working in the office started feeling very upset about having to do all this work for people that were working from home. It started to develop a divide within our team. And that was really concerning, that we had this divide within our team of like the in-office folks and the at-home folks. And it became divisive and it became unhealthy. And we really wanted our team to function as a team as prior to COVID. Yeah, I see Kim saying that she could see that. Yeah, it really did develop this way. You want to have a team that is working together and helping out and feeling a part of, all the things that came along with COVID, with isolation, with people feeling, starting to feel depressed or anxieties going up and all those things. It was really a parallel process with our providers and the people we serve. So that's why we developed that people have to come in now. And, part of COVID, when everybody went virtual and home and was away from each other, part of what we lost was that, what you call it, coffee time discussion or that water cooler discussion where you can just kind of say hi to someone, check in, have a conversation, tell a joke, whatever it is, you have that connection. You have that physical in touch, in face-to-face connection. So really with the hybrid service array, we want to come up with a balanced system where you can still have the convenience of being at home, providing services from home, not having to travel, not having to spend gas money, not having to get ready earlier, all those things, but also having people come in so they can still connect. So we require that everybody in our outpatient services is here on Tuesday because that's when we do our treatment teams. And that's where we really do some bonding activities, some training, and we want that face-to-face. We also put into place with many of our programs that your first 90 days of hire, if you're a brand new employee, you are going to come into the office for those first 90 days and be trained and work there and get the lay of the land really underneath your belt prior to then being able to work from home. And that's something that we put into place after we kind of went through. Likewise, with the clients, we used to have, it could be either way. You could come in, do your admission, and then start telehealth. At the very beginning, we used to have people come in, we'd evaluate them, we'd figure out if the telehealth is a good option for them, and then we'd start seeing them. We now have the admission session face-to-face. 1, so we can verify who we're working with in a very secure way. 2, because there's a lot of paperwork to fill out. And while we have systems that can do that in a HIPAA and 42 CFR compliant way, we don't always get them back timely, or at all. So it's easier to do that face-to-face. Plus we can get that first drug screen under our belt and move forward from there. So that's kind of where we've landed with our hybrid service array at outpatient services and how we function. In our opioid treatment clinics and programs, we continue to provide our satellite counseling from a counselor. We have satellite clinics. You're required to have counseling if you're receiving opioid treatment and medication for opioid use disorder. And so we have satellite clinics where people go and they receive their counseling from a counselor at another site. So we have what we lovingly call at all of our locations. We happen to use Zoom. I'm not promoting Zoom. That's just the platform we happen to use at my agency. And so we have what we lovingly call Zoom rooms at many of our locations. So if someone lives far away and they don't have access to in their home, or they don't have a cell phone, they can go to one of our facilities and get registered to get into a Zoom room, and then they can have a session with a counselor that may be in another county or in another site, or even working from home. And so that's helpful to set up and leverage technology and have technology available so that people can actually receive the services that they need. In those clinics too, sometimes counselors can work from home. The majority do go in, but they can work from home as well. So again, that parallel process. Case management, we traditionally have done in-home sessions as well as in office sessions, and we have added the virtual appointments and visits and check-ins as well. We also have added virtual groups in our case management services, which has been helpful. We use the groups that we developed newly, or we have ones for moms, for dads, for families. They can log in, they don't have to pre-register, all those things. And again, the case managers can also work from the office or in home. So again, that parallel process continues. Some of what we've done in leveraging technology and really looking to reach as many people that we can reach as possible is we lovingly call this little stand with the tablet on it that rolls around our parbots. And we have put parbots in, I believe at this point, we're up to 5 or 6 emergency departments in the hospitals. We have one in a primary health provider. We have them at shelters, sober support. We'll put a parbot wherever anyone is willing to accept it and to use it. And how we use the parbots is we have peers at our agency that are extremely valuable and needed out there in the community. They're really helpful in talking to folks who are making a decision whether they go into treatment or not, or if they're ready for treatment. And we love to have our peers out there. We have a total of 6 peers. So we don't, or 7, we're getting 7, but we don't have enough to go to all the places that they need to be, and certainly not be there all the time, because everybody seems to want to have them there once they have them. So what we decided is we would put these parbots out in these locations that has a platform. We happen to use DoxyMe, again, not promoting, just that's what we happen to use. And you touch the tablet, it comes up with one choice to connect. You connect, and a person, a live person, will come on there and we'll do an assessment. We'll set up an appointment. We'll put you in touch with a peer. We'll do a chat. We'll do whatever is needed. And that gives that live person connection with our agency and allows us to be in multiple places. Now, I will say, even some of the hospitals have really taken a liking to this. They have had many of the patients that are there in the emergency room due to an overdose or any other substance use issue on here and utilizing our parbot. Other places, we've had to remind them. They'll call us and say, what time is the peer going to be here today? We say, you have the parbot, put somebody on the parbot. We can get them in touch with a peer. We can't have peers at every location all the time. So it's been helpful. It takes some reminding. It takes people getting on board. I was at a job fair the other day, and I was discussing with one of my colleagues there, and I was talking about the parbot, and I was talking about, in general, telebehavioral health and certainly providing hybrid services. And, the person said to me, yeah, but it's just not the same. It's not the same on the video. It's not as good. And I'm like, oh my gosh. So I said, it's different. No, it's not the same. It's different. But if it's able to provide a service, if it's able to reach someone, if it's able to meet a need, if it's able to take down barriers, we should all be supportive of it and looking to see how within our agency we can leverage technology in creative ways so that we do break down these barriers, so that we have people in treatment and we help people get the services they need. And that's really the bottom line, right? That's really the bottom line. So that's our parbot. We also, in our residential services, we allow our residential clients, the adults, not the adolescents, we allow the adults to have their cell phones with them, or if they have a computer or laptop, they can have their laptop with them. We also have several tablets that we will allow the clients while they're in residential to use. And we've been doing this for years now. People, when we first started, looked at us like we were crazy. They said that's so unsafe. You're going to have drug dealers on your campus. You're going to have abusers on your campus. You're going to have people sending inappropriate things, receiving inappropriate things. They're going to be triggered, on and on and on and on. Our philosophy was, we want to provide a safe location where people can safely learn how to use technology, where they can understand how to use it. We give them these tablets. You can see a little picture of the tablet. We preload apps on there that are helpful for them to use while they're here. If they so choose, we don't force them. They can certainly use these apps. They can attend 12-step meetings. They can attend appointments. And that's where we got to this other collaboration that we do with EverHealth here, health provider, where they brought in their system, and this is their system. You see the panel there. There's also a tablet that sits on the back that the nurse that sits in with the client can attend. And we had the issue, I'm sure other people have experienced this if you're involved in residential care, that we had clients coming to us and they were so behind. Either they didn't have a primary care physician, or they had not seen a primary care physician in a long time. They maybe had medications that they didn't bring with them. They need new prescriptions, all of those things. And we, unfortunately, like many, used to send out to the hospital, go to the hospital and get this figured out, go get this set up. And sometimes prior to even coming into our facility. Well, now we have access to this health system where we can bring somebody in, we can sign up for the appointment. There's a special number that you call for these appointments. We can get an appointment that day or the next day, and they'll see a primary care provider. We have the stethoscope, the otoscope, all those things that click in there. That's why we have a nurse sit in with them. They do their basic exam. They can get meds refilled. Once they've done their basic exam with the primary care, they can then have access to the psychiatrist at that facility and start that process there too. Really, really helpful and valuable. We're starting this at our detox services too, but we're doing it with the county insurance that is local here, that the majority of folks going into detox are working to get, are already on. We can help them link to those services, get signed up for those services, and also do the same thing here. They have a tablet that they use, and you can set up with appointments. It's pretty quick access, and they can get things, so we don't have to send people out. It's very difficult to send a detox person who is in the middle of detoxing out for their primary care physician. So this is a way to leverage technology, to collaborate with your community, and to meet the needs of people. And we're very excited about it. These are both new things, connection with Evra and with the county insurance, the tablet. We've had 2 clients. It was so new that we have had 2 clients so far utilize it, and it's gone really well. So we're very excited about that. So as we go through this, I encourage all you, if you haven't already, I'm sure many of you have, but think to yourself how you can creatively leverage technology with collaborations in your community, to help your clients further, all those things, just constantly thinking of ways to leverage technology and offer these hybrid services, right? And why? Why should clinicians, peer support specialists, providers in general deliver hybrid services? Why is that important? Well, we certainly know that there are treatment gaps out there, right? We know that. We've known that, and we know that there's treatment gaps. Not all people who are needing treatment have been able to access it or are accessing it. As you say, and this was from 2019, and you can see only 10% are receiving services in areas. So if you really think about it, it's a way to break down some of those barriers. I know we were shocked. In our residential program, we started an endocarditis program, which endocarditis involves I believe it's 6 to 8 weeks of IV antibiotics to deal with an infection in the valves of someone's heart from IV use. And we started this with the hospital system because what was happening is certain folks were sitting in the hospital for 6 to 8 weeks for this IV treatment, and they weren't getting any substance use treatments. They would receive this, get better from that, be released, and then be back, a month later, 2 weeks later, whatever. So we decided to partner with the hospital, have those patients with endocarditis come to our residential facility, continue to receive their IV antibiotics, and receive treatment at the same time. We had home health that would come in every day, check their lines, flush their lines, do wound care, whatever was needed. And then the doctor came once a week, and otherwise they were in our residential program functioning and getting treatment for their substance use disorder. Now, we thought when we started this program that the clients that we would see coming in would have been through our detox multiple times, perhaps through our MAPS clinics, our MOUD clinics, and we would have had them in our system multiple times. We were shocked to find out that the vast majority, and I mean vast majority, of these patients coming from the hospital system had never touched our services before. So there are gaps out there, and we couldn't believe it because we're a very large substance use disorder provider, and we believe that we touch everybody and everybody knows us and they'll reach out when they need us. And that wasn't the case. These folks somehow had been lost. So again, I think it's recognizing that there are treatment gaps and there are ways that we can work on that, providing services in the way that we do. So this was 2019, so it's a few years old, and with 2021 data too. 85% of adults own a smartphone. 35% of United States smartphone users check their phones more than 50 times a day. I'm telling you, I feel like I see people that are attached to their phones. I'm not going to exclude myself from that. Looking at it constantly, right? We've almost learned how to multitask of constantly paying attention to emails or chats or things coming up, right? 35% in 2011 to 85% in 2021. So if people have these smartphones devices and they are looking at them, how do we continue to leverage and provide them services in a way that they can reach it for convenience, to break down these barriers again? So telebehavioral health in the form of synchronous live video and audio is effective, well received, and it's a standard way to practice. That became the case. It was starting before COVID, certainly during COVID, and now following what we're doing. So looking at what has happened with video conferencing, it's increased ease of use, improved outcomes in communication, and medication adherence, which is extremely important. We know that's a challenge to have people be medically compliant, to stay on top of their medications, take their medications. Decreased missed appointments, wait times, readmission, patient travel time. Certainly convenience. I know you guys have probably experienced this as well. We have several clients that we see, and they are utilizing telebehavioral health for their services. And some of them work a job where they get an hour lunch break, and that's when they do their sessions. And they go out to their car, not driving their car, but they go out to their car, they use their phone, and they participate in their sessions and then go back to work. It's that convenience. They don't have to drive somewhere. They don't have to wait till after work. Or before work, they're able to conveniently include within their day. So there's a lot of ways that people do that, and I know there's been a lot of creative ways that people have provided telebehavioral health to folks. During prior to COVID, we were tracking our no-show rates, and when I say no-show, I mean that they just didn't show. They didn't call and reschedule. They just did not show. And they were pretty high at one point, 30 to 40%. We were saying it was really bad in our outpatient services. Once we began and we went into COVID and we're providing services via telehealth 100%, we had 30% less no-shows. So it really is helpful for people. It was helpful for us because we did reminders too, texting reminders. And we had a system that would also call. It was one of those, most doctors and dentists and other providers, even my hair stylist has them, where they give you those reminders for appointments. I think that helps as well. And so to get on to that, during COVID, there was guidance to allow for some audio-only telehealth services. When you look at the Florida statutes currently, and I'll just read, this is the Florida statute. Telehealth means the use of synchronous or asynchronous telecommunications technology by a telehealth provider to provide healthcare services, included but not limited to assessment, diagnosis, consultation, treatment, and monitoring of a patient, transfer of medical data, patient and professional health-related education, public health services, and health administration. The term does not include audio-only telephone calls, email messages, or fax. Okay, so during COVID, there was a lot of allowances made. There was waivers and flexibilities, and those were during COVID, which are about to meet. What statute is that? That is Florida Statute 456.47. It's also in the Administrative Code 65D 30.002, basically the same language. It says at the end of this one, telehealth does not include the provision of health services only through an audio-only telephone, email messages, text messages, fax transmission, U.S. mail, or other parcel service, or any combination thereof. Now, with that being said, there is a bill out there, a sponsored bill both in the House and Senate, looking to eliminate the explicit exclusion of audio-only telephone calls from the definition of telehealth in Florida's telehealth practice standards. So it is looking for that to be removed so that the audio only. There are states out there that allow audio only, 100%, right? They allow it, and it's reimbursed and all of that. So what I would say on these is it's important to keep, obviously it's important to keep up with them. The things are changing starting May 11th. Some of them are going to expire. Some of those waivers and flexibilities will expire. Some of the temporary flexibilities and waiver will expire on that day. Some of the flexibilities will have been extended for 151 days after that, and some have been extended through December 31st, 2024. So if you go to the Center for Connected Healthcare Policy, the National Telehealth Policy Resource Center, you can find this information. You can, there's several sites that you can look up. You can obviously go to the statutes themselves, or to go to 65D itself and look these up. You will need HIPAA signed consents. Yes, those have to be in place now. Those were waived there for a while, but they will now be there. And if you're a substance use provider, remember, along with the HIPAA, you need to have the 42 CFR Part 2 requirements as well. And yes, people will need to sign those. I can put this really quickly. Let's see, FL statute 456.47. And then it is also Florida Admin Code 65D 30.02. Okay, there you have it. So I would say, I would encourage you, if it's not you, I'm very fortunate. I do some of it for my agency, but we have a compliance officer that's very good at looking at these things and will look them up for me and give me little hints and updates. You can, on some of these sites for telehealth that looks at the laws in various states, you can sign up to receive email notifications. So I encourage all of that, and to discuss it over with those folks at your site, or if it's you that are the provider, to actually look these up, keep updated, because you can see things are changing as we're coming out of COVID. So making sure you're doing that. There are a number of folks and people that use texting apps. If you're going to use texting at all, you should probably look into an app that is HIPAA compliant, right? And make sure that it is, make sure that it's not testing clients using SMS testing should not be done, right? So you really have to look into that. We have a system that we have clients sign a release for texting, and the texting that we do is only about appointment reminders. You know, you can't control what a client will send you, and oftentimes they'll send you a mile-long notice of this happened to me, this happened to me, this happened to me, what do you think, blah, blah, blah. And we can't respond to those, except that I'll see you at your appointment next Tuesday at 3 or whatever it is. And we're clear with that, and we have them sign ahead of time to know that. right? But clients, when you start connecting with people through technology, it seems to have this weird translatable message that you can communicate in any way, right? Unless covered by waiver, correct? Can communicate me with technology anyway, anytime or whatever. So make sure that you're very clear with what kind of technology you use to communicate, how it's done. You're updating people, both the providers, if you're an agency, as well as the folks you serve. Extremely, extremely important. Okay. So what we have learned, and I'm interested, that's why I asked the question of you guys. I asked you how your providers felt about providing a hybrid level. And because sometimes with the video conferencing, it is the providers that express more concerns about it and worrying about it, either providing it or if it works, all the things. And I know when I started, and when my CEO came to me and said, hey, we're going to really open this up in outpatient services. We're going to provide telehealth services to the clients we serve. And I have a client that I would like you to start this with. And while I'm shaking my head, looking at her like, okay, great. That's what I'm saying to her. Inside my head, I'm saying, oh my God, this is awful. Like, what are you talking about? How am I supposed to actually develop a relationship with this person through this camera? Obviously, my thoughts have changed completely on that. But oftentimes it is the provider, and whether it's the fear that, oh my gosh, I got to learn my job in a different way. And that's scary because I don't want to have other people look at me and say that I don't know how to do my job, or I don't want to feel silly or weird, or what if something happens? Let's see, our providers often provide counseling sessions with clients can engage in the regards of individual sessions. Yeah, absolutely. And it's interesting that you say illness there, because this particular client that my CEO asked me to see had leukemia and really was at the end stages. Couldn't come into the office because sometimes just really didn't feel well and wasn't able to get out of bed. But beyond that, didn't want to be exposed to all the folks that would be here. So it was a lifesaver. It changed my feelings. That one client changed my feelings on telebehavioral health so incredibly. And that's why I got so passionate about discussing it and advocating and really becoming a cheerleader for the cause, both at my agency and in the community, is because of that one client. So I saw that client for, I believe it was about 5 months, worked with him and his wife. I had to work on family of origin issues where he had been estranged from his family because of drug use, had to work on marriage issues, and then I had to work on end of life issues, all through telebehavioral health. I never met this gentleman in person, but I can say it was the most powerful and meaningful sessions that we would have. So much so that he brought me to his cancer treatment center and was on his tablet, had me interact with the doctors because he was worried. He didn't have a family member that could go with him. He was worried how it would affect him. He was receiving some news. He didn't feel he would be able to maintain all that news. So I was a part of his treatment team in that way. Right, going to some of his appointments, being in touch with his doctors, talking to him, talking to his family, very powerful. And I would say the family afterwards told me they felt like it was so incredibly useful, and it wouldn't have been able to be done without telehealth. So that one single-handedly changed my thoughts on it, and really I felt like was so valuable for that family and for that person. So again, many clinicians have concerns about the services with telehealth, of how you engage them, how you develop therapeutic alliances, how you develop trust, how do you develop therapeutic relationships. And that absolutely was my concern. That was 100% my concern when I started, because if you are formalized, have formalized education within this field, what you're taught is the relationship is the most important factor in working with clients, right? The relationship, not what theoretical perspective you're coming from, not what evidence-based practice you're using, the relationship. And I really believed there's no way you're going to develop a relationship like you do when they're sitting in front of you. And I think, people also have concerns about using new software or programs or technologies. we have folks that have been using technology their entire life, to folks who started using technology in their 20s, even their 30s, even later. And so I always say to people, don't judge a book by its cover. Just because it's a young person, don't feel like they're going to be a whiz on this. And just because it may be someone who is in this field for a long time, that they're not going to know how to do this or be able to engage with people. We had a director, she was actually a vice president, that was in her 80s here, right? And I thought, oh dear me, we are not going to put her on telehealth. What are we doing? And you know what? I think she was better at it than I was, for goodness sakes. Like, she really got into it and figured it out. So that was really, really, really cool. So yeah, what does research say about age? Many concerns about young clients. What some of the research says, I think I have it later on, but it really talks about that, there's going to be different folks that engage with the treatment through video conferencing in different ways. And I'm sorry, I do behavioral health, telehealth, video conferencing. I all interchange those words, but no, I mean the same thing. That the younger folks who have been around it all their lives, they don't have concerns about it for the most part. They really, it's part of their life. It always has been part of their life. It's really how they engage with their friends, how they did school for an entire year or more, so they're really, it's not typically an issue for them. And it is not typically an issue for other people as well. It just depends, their fear about it, if they're able to remember. I know my mother-in-law would struggle tremendously because she struggles to know how to respond to text, So I think it's really about training, and we'll get into it later, and really assessing if this is the best way to serve somebody, right? So again, people get concerned about confidentiality and privacy and security issues, and that's training, that's giving them the facts and helping them understand how this works. Questions about health efficacy. Does this even work? What does the data say about that? How do clients, and I was thinking about this morning because we're developing a new client satisfaction survey because of this hybrid service delivery. And one of the questions I want to ask, I want to gauge how the folks, the ones that are doing hybrid, meaning that they may come in for some of their sessions, or they may come in for group, they may get their individuals online, whatever, how they feel about that. And I also want to ask those questions that are on some of the client surveys that people do within their agencies, asking, do you feel that you have a good relationship with your therapist? Are they responsive? Do you feel connected? Those kind of questions, to see where they come from, to get some data from the clients that we serve. And then of course, laws, roadblocks. Laws can be scary for folks to figure out and look at, and other roadblocks that come along with it. And I think these are the concerns that a lot of providers have, right? A lot of providers have. When you ask about young clients and research, I think, when you get into the young clients, I'm not so up to date on the research on that, like working with children per se. I know that sometimes it can be challenging, but I do know that there was a group out there that was doing play therapy, observed play therapy sessions with younger ones. Of course, that means that if the child is at the facility and they were doing an observed telehealth or play therapy session from somewhere else, that they had someone at the office that would set up the room, kind of give some instruction, maybe there was a parent there, those kind of things. So I think it's really about looking up specific to the population and what others are doing out there and how they've been able to work with different populations. So again, this one I think is common sense, the first one, but it also is like, oh yeah, that makes sense. Clinicians with more telebehavioral health knowledge and experience tended to have more favorable opinions. Makes sense, right? If you're trained, if you understand it, if you have practice, if you have a supervision on it, you feel more confident about it. You feel like you can see some success, especially if you see some success or have a client like I did that really benefited from that service. And so I think it's really about practice with feedback, observing, assessing experts, all of that, bringing and sending people to trainings, bringing in trainers, doing role plays. We created, when we first started the groups, that we took the groups completely online during COVID, completely virtual. We developed a Zoom group skills practice session, and it was all laid out. We had people practice it with their supervisor. So they were to, we create a group, of colleagues, and we'd have the person log in, start the group, do some of the skills, and we laid it out what skills we would like them to practice. And it was things like share the whiteboard, ask us to participate in a poll, or whatever it was. But doing those things so people got comfortable with it and understood it. And if there was a glitch, or if there was a delay, or if somebody had difficult with technology, they were able to practice it in real time and gain some confidence in that way. So I think it's real important. And ongoing of this, I know that I had some discussions with some folks who are very involved in telehealth and have been for years. And we were talking about doing clinical supervision with folks who were hybrid or providing all telehealth services. And what we were saying was, how do we do observations? Do you log into the session yourself, introduce yourself, with the client would know ahead of time, they would have gotten permission and all that. And then you have a black screen while they conduct their session and you observe it? Or do you have them video record the session? Or do you have them audio record the session? And it's an interesting concept because we know what we do. Most people have set up what they do. If they observe sessions, or if they record sessions, or however they do it for live sessions with folks. But really looking and examining how, with clinical supervision, do you provide that supervision for folks that are doing telehealth services? That's really important because it's a different skill set, right? There's different skills that go into this. And so I was saying I would prefer to have a recorded Zoom session, permission from the client, of course, ahead of time, all of that. An assigned release from them saying that this is used for education purposes, it's for supervision, it will be destroyed, all those things. But then it's taped that way so you can look at the person providing those services, how they use the platform, if they are looking at the camera, if they're not looking at the camera, are they distracted? Are they doing other things? All those things you need to look at with telebehavioral health, you can do in that way. Some people liked to log in and actually be on the session, blacked out while the session was going on. I just feel weird about that because I feel like that could be triggering to people, knowing that another person is sitting there live but is blacked out. I don't know. I personally like the video, but it's really up to other programs, because I have another program that they know they do sit in on them, and that's how they do it. So just some food for thought on how you would do that. And Kim, yes, I will reach out to you. So I think those are some food for thought on supervision and how to work with clinicians, because what happens with telebehavioral health is that there's a switch. With telebehavioral health, clinician has the most burden placed on them rather than the client. It's not about that, you have a client come into your office, the client comes in, it's really their responsibility. What are you here to work on? What would you like to work on? How would you like us to work? It's really a lot of it, the ownership is on them. And not that the same ownership isn't on folks when they participate in telehealth. But what changes is the clinician has to do more checks and balances. They have to come in and they have to make sure their audio is working, the client's audio is working, the video is working, their video is working. They got their safety checklist, and we're going through that in a little bit, that they've gone through. Make sure ahead of time that you've opened the electronic health record and you only have that client's information showing. That if you are going to access any other kind of documents, anything to send to them, email to them, or put them through a system for them to complete, or for them to have, or any other brochures, videos, whatever, that you have that pulled up and ready to go and you've tested it. All this is a lot to do before somebody gets there. So there's a lot more involved. The clinician has a lot more to be concerned with than when they just walk into your office. Let's see, Gen X seems to be least comfortable learning these days. Yeah, I agree with that. I happen to be Gen X, so I found that younger people whom I seem highly confident online were actually, yeah, I agree. That's what I would say. Don't read a book by its cover, because some of the younger folks we have too have struggled getting some of the things we've done down. And I was surprised. I thought it would just be second nature and they'd be able to do it, but it's not always the case. Do you believe that assessment are complete with common knowledge on how to compared in person? Do you believe that assessments are completed with? That's a good question. Let me get back to that one, Kenneth. So there's a lot to do ahead of time before you get to the actual session, right? So can you elaborate a little bit? Do you believe that assessments are completed with common knowledge on how to complete compared to? No, I think that I mean, if you're asking completing assessments via telebehavioral health, I think people have to be trained in a different way as well, because it's at least for our agency, when we complete assessments face to face, some people have multiple screens and can have the assessment questions turned around and they can enter them as they're answering. Some don't. Some answer the questions and enter, but don't have the client seeing the questions. So I think I would like, for when we train folks to utilize telebehavioral health, we walk them through everything, and we attempt to have a supervisor walk through them first and look at it and talk about it and problem solve and all that prior to see. I don't think that people naturally know how to do it. I think, and where it becomes dangerous again is that setup at the beginning. You know, you have to share your screen if you're doing it virtually and you want them to see what you're doing. And sometimes people forget how to, if you have multiple screens, they share the wrong screen, or they have another client open in a chart, and then they've disclosed, you know, they've broken HIPAA and 42, all these things. So I think we really like to have you practice. It's hard. It was hard when we had to go virtual because of COVID. We had 2 weeks to get everything done, and we have just under 500 employees now. Not all of them are conducting services, but you know, oh, good. I'm glad that was the answer. So it's hard. I think it's a complicated factor for sure. It's hard to train people and keep up on trainings. And luckily we have at our agency, because we are a large training committee, a training team that consistently provides trainings. And one of them we have is telebehavioral health and a variety of others. And we can have people, we can sign people to go back through it. We can work with them as supervisors and individual supervision, but I supervise all the clinical supervisors. So I absolutely tell them that this is a point that they need to get across, and they need to work with folks and actually help them observing them, doing role plays and practicing these things for sure. So again, engagement, therapeutic alliance, and presence, those are all extremely important things that we do when we see people. We work towards, and we do when we see people face to face. And we also need to do that when we see people via telehealth. And obviously we know it's important for effective treatment. And I think when you think of how you do this, how do you start that therapeutic relationship or that engagement process with someone online? Because it's different than when you walk somebody from the lobby. You know, you get a call from the front desk, your client's here or whatever. You walk up to the lobby, you get them, you say, hey, how are you? Oh, you got your hair cut. Oh, good to see you. What's the weather like? Blah, blah. As you're walking to your office, maybe you offer them a water or a coffee. They come into your office, sit down. You've had that little engagement period there, that little connection time. When you log on, and especially if you start like, okay, let's check your video. Can you hear me? Can you do that? That's not, it's a process that you must get through, but it may not have the same effect of developing that engagement as when you're live. So how do you develop that? Same thing. You know, as you're doing your check-in or whatever, you can maybe you throw in like, oh, the weather's been so hot here in Florida. Good. Summer is here. The heater is on, or whatever you do. Just those little talking points that you would naturally do live. Looking at that, watching the tone and rate of your voice. How your body language is presenting on camera, all those things, very important to work on, that you start that engagement process. And this is from NAMI. Engagement and treatment is defined as the strengths-based process through which individuals and mental health conditions form a healing connection with people that support their recovery and wellness within the context of family culture and community, part of the therapeutic alliance. So it's really, it's you know, connecting with people, supporting their recovery and wellness, and how we talk to the folks we supervise about being able to do that live and through telebehavioral health. And they may do that multiple times during a day. They got 3 sessions in the morning that are all telehealth, and then this afternoon they're going to run a live group, and then they have how you make that switch. You know, you're taking on one hat and putting on another, and you're back and forth. Some people are quite capable of taking their attention to different places quickly and fully, and some people are not. That they may just have a session that they see a live person and then they go to switch to telehealth and they forget, oh, wait a minute, I needed to do my check-in. I need to do the safety check. I need to do a bunch of things. And I've already started this session with this person, So you gotta make sure that people recognize that you're doing two different kinds of service deliveries, and you may do multiple ones during the day. And how are you going to switch back and forth and practice that? Really, really, really important. And presence, so important as well. The presence enables therapists to be physically, emotionally, cognitively, spiritually, relationally in touch with themselves and their clients. And so just, I know it's so important. I'm not going to read all of these for time's sake. You'll certainly have these slide deck and look at it, but it's a crucial factor, right? It's being fully present. And what can happen, and we know this, what can happen when you are participating in telebehavioral health is that you got your phone in front of you and you're getting some kind of text, or your email is up on your third screen and you're seeing your email come across and you're reading email as you really should be present and paying attention to this client, that you would not do if you were in a live session, right? So we really have to work. Yes, sometimes I take them off to show them I have time. Absolutely, you got to be present. And that was one of my ways of challenges to you. How do you yourself and people, love that you're throwing ideas out here. How do you develop this presence through the telebehavioral health? What do you do with people? Right. Even a touch of hand seems empathy in a way not online environment cannot, right? So how do you do that? Like in person, you may reach out, you may hand them a tissue, you may lean forward, you may do all these things that online you can't do. So how do we develop that presence? It's crucial. All right, at this point, you guys, it's 5 to 11. Well, it's 4 to 11, but we're going to take a 5-minute break, okay? You can go get something to drink, take a break, use the restroom, get a snack, whatever, and we will be back here at 11:01. Sure, Kenneth. Yeah, Kenneth, if you want to type your question. You believe there's a hospital discount with telehealth? Kenneth, I want to address this with the whole group. It's a very good question and very important. So when we get back, that's where I'll start. I appreciate it.
Okay, everyone, the break is over and we are going to get started again. And I'm going to pass the presentation back over to you, Sandnes.
Thank you. All right. So I know, Kenneth, I'm going to reach out to you. I know you had put in the chat question. I've lost it. If you don't mind retyping that, because I did want to address with everybody. It was a good question or comment. So we were ending with presence. And I just like this, say how this is worded. A clinician's highest calling is to comfort others in their suffering, a fundamental contribution to our own sense of purpose and meaning in our work. While there's no standard definition, we identify presence as undistracted healing engagement between clinician and client. And I love that part, undistracted healing engagement. Again, that is where it's super, super tricky with telehealth, as there's so many distractions, both, again, it's a parallel process, both for the provider, the clinician, or peer, or whomever, and for the client. Both sides can have many distractions when you're participating via telehealth. All things to be aware of. So looking at Therapeutic Alliance, and this is from an article, and this was actually discussing psychologists, but here's where we go. The sharing of clear expectations and goals by both clients and psychologists. So again, asking the client, what are you here to work on? How is it that you would like to work? Here are the list of development goals, whatever, and being on the same page, having a clear definition of responsibilities, rules, and commitments. And honestly, certainly when you're running group online, that's a whole nother ballgame. We'll get into that a little bit about rules and guidelines and responsibilities, but there's increased of those with telehealth. And like we said, a lot of that burden is on the clinician's part in gathering those things and developing that trust and mutual respect. Again, this is about connection. I'm not going to read the whole thing, but you can see different ways. There's different ways that people look to form connection with folks, and you guys had put some things in there, as well as looking at using a lot of reflection, using a lot of empathetic statements, increasing of verbalizations, right? Using your best MI, all those things that we do live, you may have to do at a heightened level. And certainly the goal of technology is to stimulate real-time experiences related to feelings, perception, images, and interaction. Create an environment that facilitates therapeutic engagement and emotional well-being for all parties. Certainly that is the goal with telehealth, just as it is with live. Now, as we all know, and we've been saying, technology may change the nature of interaction for participants, communication related to exchange of information, clarity, responsiveness, and comfort. I know we used to say when we did a lot of these telehealth trainings, specific for telehealth, we'd say things like, it's the same but different. The goal is the same. Maybe some of the concepts are the same, but you do it in a different way. And that's really important to communicate, especially those that are struggling. Again, that's where supervision, practice comes in, all of that. Making sure that you're identifying evidence-based practices that work best through telehealth, how you're communicating, how you do that differently, sharing screens, videos. There you go. Oh, looking for a video on motivational interviewing. Absolutely, there are some good ones out there. So yeah, making sure you have how you're going to practice identified and actually discussed in supervision. So again, all of this really goes down to your telepresence, right? A mental state in which the user feels physically present within the computer-mediated environment. Telepresence is the clients, caregivers, and clinicians that experience realism during a telehealth session that is created through connection. So you're developing that telepresence. And really, when you have that telepresence, there's a lot of aspects you can see here, how it all spreads out. But really, I always think of the experienced realism and being in the room. You have entered virtually through the computer screen into that client's house, into their office, into their car, into their wherever outside their house, wherever they may be participating in, right? So that brings you in there, and you may see things. Just back in the day, I did in-home sessions a lot, and I would see and hear things and be a part of things and witness to things that I would never have seen if the people had come into the office. And so I conducted a Zoom interview with a client in a room with a child watching TV, client smoking, and he drinking what could have been alcohol. Yeah, these kind of things happen because you are now in that person's space, and people have we're going to go into disinhibition effect, and they're participating as if they're in their own house and you don't know. And this also goes into ethical dilemmas and setting up the telebehavioral health session, right? Certainly, if you walk in and a client is smoking, we don't allow clients to smoke while they are in live sessions. And so we like to say our telebehavioral health sessions are just like live sessions. They happen to be on video. So we ask people to be dressed appropriately. It's funny you have to say that, but yes, we do. To be dressed appropriately, to not smoke. Really, we'd like them not to drink. We don't have them drinking or eating in our sessions either. We don't drink or eat in our sessions. You know, I've noticed even providers have gotten a little slack on that they'll drink and eat in their sessions. Now there's time, if it's in the morning, I know I've been said to a client, like, I have a coffee. Do you mind if I have my coffee here? It also helps me with my throat if I'm talking a lot, and you know, that's fine. So I think it's one of those things you do have to have the discussion, and that is the burden, and that's where people start feeling uncomfortable sometimes, right? They feel uncomfortable saying, okay, like, it's really loud. I hear something in your background. Can you slow that down? Can you move to another room? You have a child that's watching TV. It's really loud. I can't really hear you. And those may be times that it's not a good idea to do a telehealth session at that time. It may be something that you set up when we have people agree to participate in telebehavioral health sessions. We have some of those discussions. We have a telebehavior, I don't remember what we call it. Our yes, I do, telebehavioral health guidelines. And on there, it has things like, you know, a quiet and private place, you know, a background, you know, without distractions. You know, all these things are laid out clearly. They're spelled out clearly for the client to see, and they initial them as we go through and discuss it. It also goes through in our guidelines that, you know, how you get on, that you can contact your provider in this way. We do not contact anyone through social media. We will not contact people through social media, all those things. And then I just do reminders like, hey, remember we talked about having a privacy in the background. Is this maybe not a good time for us to have a session? You can do those things, and it's hard. And again, the burden gets placed on you in a different way because you have to be so much more direct. Then you already have the environment taken care of when people come to your office. So again, I think you have to train people how to have that discussion with people where they're not being harsh or going for the jugular, that they're having a connection, a conversation about how the telebehavioral health session can be most effective, right? And you do that through, one way is developing trust, right? One way that we develop trust when we're sitting face to face, people, is making eye contact. Now, there are some cultural things that go along with that. That's not great for every culture, but in general, recognizing that making eye contact, you know, calling people by their name, right? You know, remembering what you had at your last session, remind yourself, and being able to say, hey, in our last session, we discussed whatever. All these things. So what we need to know is how to do that through telebehavioral health. And one way is that if you look at your screen, which you are looking at the client, if you look at your screen, you're not truly making eye contact. You really have to look into the camera to really make eye contact, which is weird because then you're not looking at the client. So I used to put a little sticker, I had this little flower sticker I put next to my camera just to remind me every once in a while, let's just glance up there and have a look. And do that. Children don't understand confidentiality. Absolutely. So, William, what I would say is potential, in some clients, you explain it and they still don't understand it, or they'll say something like, well, I don't care if my spouse hears this. I don't care if blah, 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 blah. And you don't know what's going on. I mean, maybe they're in an abusive relationship, maybe they're in a difficult relationship, and that may be where you have to have the discussion. Telebehavioral health may not be the most appropriate way to provide services. Maybe we have to start off in office, develop some stuff, and then maybe we can try it. Maybe we do groups this way and not, you know, it just depends. But I think you always have to look at that, because you still are responsible for protecting people's confidentiality. And sometimes we have to help people protect them from themselves, right? They may say, like, I'm cool with my wife hearing this. And I had this situation. I had a couple, not a couple, I was working with the husband, And there were some marital issues. And so the deal was that the wife, the spouse, she worked from home. So she was to be at the end of the house in her office, and he was going to go to the opposite end of the house or even outside and have the sessions. And one day we're having the session, and he's telling me about a situation that occurred. And the next thing I know, I see my email blowing up. And I have 3 screens, so I can look at my email. It's from the wife, and she tells me, he's an effing liar. Stop talking to him. Da, da, da. You know, I'm like, oh, hey. So I said to my client, I said, your wife can hear everything we're saying. She's emailing me now, and she's not too happy about it. You know, he said, oh, I didn't know she could hear. You know, and so it turned into a situation. So sometimes in that situation, I said, I think we need to bring this into the office. And we worked together prior to going back to telebehavioral health, and we actually turned it into a couple sessions. So I think it's one of those things that you have to really look at and evaluate and make sure you're doing that. And you're going to have to train clinicians to do that, because clinicians don't have to do that in office. It's not an issue in office. So having to do it and having to be more forward, having to say, hey, this may not be the right time to have this session, that can be hard for people. It really can. And people just want to ignore it. And they just keep going, and they act like it's not happening because they feel weird, or they don't want to cut a client off, or all the reasons. So that is a role play. These things that you guys put in the chat, I would role play these with the people that I supervise all day long and see how they react and how they connect, so that when they are in a situation, because it will happen, that they're able to problem solve and figure it out and get to a place that is healthy and working for the goals of the client, for sure. So again, collaboration. And I think that you have to be open and available. You have to create the space for that. Just as we hold space, if I don't say holding space 12 times a day in my in my job, I don't know what I say. I say it more than anything. So I think holding space, and you have to hold virtual space as well as hold live space for people. And that includes virtually or live, holding emotions, holding content, allowing that safe place. We're trained, most people have been trained to do that live. It's a different feeling, again, through telehealth, and it's really important to be able to practice that. Also, again, talking to people, I think this is an important factor, and I know I keep saying it, but that people may be back and forth throughout their day of how they're providing services, and this is a good time to talk about how are they doing good self-care. This is a different way of operating. It may feel more draining for folks. They may report feeling, getting more burnt out, or feeling more stressed, or feeling, fill in the blank. How are people taking care of themselves? And it's really important, as we are having people enter into this hybrid service delivery model, that we are providing them resources. And because again, it's a parallel process. We have to help our providers maintain solid, good self-care, so that they're able to hold space and hold that emotional content for the folks that we serve, so that they can develop good self-care and good coping as well. So of course, our goal, and I can hear my CEOs saying it all the time, longer lengths of treatment, allow the clinicians to be supportive to clients across their recovery plans. It has a better trajectory if we keep people in treatment, as opposed to people coming into treatment and then stopping, and because of barriers or whatever. So in that, it's a way to reduce barriers. And sometimes, that's why we have a clinical team in outpatient specifically that looks at situations where, is it better to offer the telebehavioral sessions, even though it may not be the most ideal situation, that they may be sitting outside, or they may be in a room in a house, there are other people in that house. Is it better to do it that way, as opposed to not being able to do it as consistently or at all? And we have those kind of discussions where we have to look at it and really see how we can support people. And at the end of the day, it's really about supporting them. And this one I found interesting, where it says researchers found that video screen invites intensive gazing. While individuals are speaking, clinicians are able to observe and support them with problems or symptoms they may not otherwise have difficulty verbalizing. So I know when I've provided services through telebehavioral health, I've seen people look, when I stopped, or when they're talking and I'm looking at this one, they'll say, wait, is your sound on? Are you still there? You know, and so it's funny, it's interesting. And so that's one concept that I've observed, but I think you can observe people in a different way, certainly in their environment. When you have them on telehealth, let's see, I find that I'm much more sensitive to how I look. Yes, it's an interesting, and that's another, thank you, William, for bringing that up. That's another concept that's very important. When you are on telehealth, we require people to be on screen when they're on sessions with us, and we require our providers to be on screen when they're on sessions with us, when they're providing sessions for us. And what that means is that, yeah, some people find it very difficult to look at themselves on camera, to see themselves there. Now, there's ways you can adjust your screen so your picture isn't as big as theirs, and so on and so forth. And yeah, only from the neck up. So you're really looking at people from the neck up. And I'm sure you've had the experience I have many times, and it always just kind of blows me away, that you've developed relationships with people through telebehavioral health, and then they come in for a reason or whatever. You're like, wow, they're a lot taller than I thought they were. My goodness, they look different than how you've created the image in your head. It's very interesting. But yeah, so I think it's very important that you have to pay attention to what you look like. If you're moving your hands all over the place, what you're doing, it's kind of in your face. It's like you wouldn't have known this before unless you were videotaping your live sessions and then observing how you held. I know one of my clients say, you have a face. And I said, what do you mean? She said, right before you're about to tell me something that you think is really great or really, ooh, look at me. She said, you get a face. And I can tell it. And I said, I don't get a face. In my head, I'm saying, I don't get a face. And now I do. I've noticed it in my telehealth sessions. I can see. I'm like, oh, I do have a face. Oh my God. So it's very funny. It's very funny to do that. All right. So again, we're talking about being fully present. For time's sake, I'm going to go by this one, but you do have to develop that connection. You have to develop that connection because it will have an impact on how successful you are with the client if you don't develop that connection. And they may not return. They may have a telebehavioral health session where they don't feel connected at all, and that could lead them maybe to not return. And that's why it's important to have those discussions about, is this the best way to serve you? Should we keep serving you this way? So on and so forth. So technical quality of the telehealth session is of lower importance than the clinical usefulness of the session. I like that, right? And that's way back from 2001, for goodness sakes, on that one. So think of that. Even if you're having technical issues, I used to have a gentleman that every single time he logged on, we had to adjust his sound in some way, shape, or form. He either couldn't hear me or I couldn't hear him. Every single time. And it would take 10 minutes to do that. And that was 10-minute hour session. And I kept thinking to myself, oh my God, this is such a pain. Is this even worth it? Is this helpful? Blah, 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 blah. But at the end of the day, really having that session for the time we were able to have that session was very useful. So when technical issues happen, how do you continue on? I'm one that uses humor. I like to use humor, and it's natural for me to do it with people live and whatever, and I'll just be like, here we go again, technology, yay. Make a joke about if something's happening. I say, let's figure it out. And just being able to remain focused and present with that client and not freak out. So many of our folks that provide these services may get to the point where they turn into fight, flight, or freeze in these situations because they're so nervous. They're like, oh my goodness, I'm going to look, it's all those messages we give ourselves. I'm going to look like I can't do my job. I'm going to look unprofessional. I really don't know what to do, which we should never have that because we have trained and practiced with them, hopefully. So being able to walk through some simple problem solving with technology, having a plan, having people be aware of the plan of what they can do when that happens. If you have to switch, if you're allowed to have a phone, if that's a thing, if you can call and reschedule, if they can, whatever, you have a plan for it and you develop it and you practice it with folks so that they don't find themselves caught off guard and confused and scared. So with that, minimally, clinicians using video conferencing platform or behavioral telehealth should be able to show their capacity to use technology with basic skills and to troubleshoot problems minimally. So that's something that everybody has to aspire to train and to keep up on and to monitor and supervise. Advise and help patients or clients with their use of the selected technology platform. You should know, you and your providers should know your platform inside out, up and backwards and down and sideways, and how to use all the functions and all that. That is a practice thing that should happen for sure. And then they should also be able to explain to the client, and that's where we have our telehealth guideline sheet to give people prompts and have people initial and really understand, and to help them understand what platform we use, how privacy and security protected, how it functions, how we'll communicate. All those things need to be explained and understood by the client, and the clinician should be able to do this easily. So again, we were talking about this earlier. Some populations may be more comfortable with technology, children in general. And when it says children, I believe it was talking about youth and older children themselves. Obviously, we've talked about some of those challenges that we had in the chats. Clients with significant behavioral conduct, substance use disorders report less stigmatization. Anxious clients report less anxiety with telehealth. So, you know, we've had people that have social anxiety and have had difficulty coming into our programs for services, and certainly telehealth has helped with that. Those with so with us, if someone is actively using substance use, if they're actively using, we try not to use telebehavioral health because it can be more difficult to recognize sometimes if they're under the influence. We have them come in for a while, and everybody has protocol for when a client shows up and they're under the influence for a group or for an individual session. What you do, you also need to have those same protocols, or same protocols in concept, but perhaps different for telebehavioral health when someone shows up and they're under the influence. Do they have a plan in place that you call someone? Are they safe? Are they at home? Have they driven? You know, all these things. What do you do? And have, again, that be a practice role play that you do with the people providing services so they know exactly what to do. And we started talking about this a little earlier, the disinhibition effect. It's when people will do or say things in text or through camera or this notes, you know, in cyberspace, more uninhibited and express themselves more openly than they would if they were standing in front of you. And that's just what this disinhibition effect is. And we certainly have all seen it if we provide services this way. And we certainly have you know, had to walk through scenarios, had to problem solve, had to figure it out. We had a client that was on with, and the clinician was a younger female right out of grad school. And the client was a teenager male, and the client logs on for his session, and then he turns his camera around real quick, and there were some other look like friends in the room. And the client says, "See, I told you she was hot." And the clinician got so overwhelmed and anxious that she just cut off the session. Didn't say anything, just cut off the session and came running down the hall like, "This just happened," you know? And so we had a discussion about, you know, okay, that's fine. We'll call, you can call the client on the phone and have a discussion of whether, you know, maybe it's better that they come into the office, or we have a discussion about boundaries and about that sessions should be treated just as if you're coming to the office. And this is important, and really, showing me to your friends and having those kind of discussions, it's really not appropriate for the situation, whatever. So we had to walk through it, which was an interesting thing. Yes, thank you. You should always purchase your platform. Do not use the free version. The free versions on these do not have, and I have another slide, you know, may not be HIPAA compliant. They also, you need to have a BAA, a business agreement associates signed with your platform so that you can ensure that HIPAA compliance is there and you can show it. So there's a lot of platforms that will give you a free version. It's not wise to go with that. Thank you for putting that there. That's extremely important. So some ethical dilemmas, and you guys presented some. These are some that I've used in my other trainings. There's a million scenarios that you can go after. Feel free to use these for any kind of training that you want to do. But these are some things that have happened. You know, somebody already brought the smoking one. This one happened to be a vape, because there's this concept that people feel like vapes are so different than cigarettes that it should be fine to smoke them anywhere, but that's not really reality, especially because in vapes you can put all sorts of things. Let's see, your client logs on while driving and says, I don't want to miss my session, and says, no, I'm comfortable. I can talk and drive. It's no problem. We do not allow people to drive at all. I would hate to be on a telebehavioral health session and have someone get into an accident because they're having to be distracted and have their attention in two different places. You know, you really shouldn't allow that. People can be in their cars, like I said, on lunch or whatever, pull over. When we get to the safety checklist, one of the things is knowing where they are. I had someone I supervised that had someone who was did deliveries for their job, and they would use their lunch break for their sessions. And so they would oftentimes be pulled over in a parking lot somewhere, at a park, you know, wherever. And you really need to make sure you have the address and location and where they're pulled over and parked, because God forbid something happens, not even related to mental health or substance use, which that could happen too, but you know, it could be a medical issue. What if they're allergic to bees and they have their window down and they get stung by a bee and they don't have an EpiPen with them? You need to get emergency services to them. How will you know where they are if you do not ask where they are? So making sure when we get to the safety checklist that you have people understand that and follow that each and every single time that they use it. And so things like, you know, you finish a behavioral telehealth session and thought you logged off, you hear your client and partner and what could be a domestic violence incident. I one time had a session and I thought I completely disconnected from the session, and I had my headphones on, and our front desk person came into my office, and thank goodness she was just asking me if I wanted to be a part of the order for lunch that people were putting in. And I hear my client say, yeah, I'm still here. And I was like, oh my gosh. But God forbid that the front desk person that walked in and said, your next client, Joe so-and-so, is here. You know, again, that would have broken confidentiality for that client, as my client was still on my headphones set. So you have to make sure that you disconnect. If you hear something, so if you accidentally don't all the way disconnect and you hear something like this, you know, I've asked people in the past, just put in the chat, what would you do? What would you do if this was to happen, or if you were supervising somebody where this situation occurred that they thought they logged off and then they heard this go on? So if you want to chime in the chat, that's great. We'll go through some of that. And you have to serve as a role model. You have to set the stage. You have to make sure you are turning off, and I saw people say this too, turn off your phone, maybe turn off your email if you're not going to be able to be distracted by it. Turn off chats, avoid any distraction. Most of the platforms have a virtual waiting room where people can be in the waiting room, and then you allow them into your session. There was a time that those weren't on all the platforms, and there was a time too that people could just log directly into a session. And if you had given people the same session number, people could log into a session and be right with someone, right? So you have to be careful of that. So, okay, what would you recommend if a client needed to be Baker acted? So yeah, if you're what we do, and I'll skip ahead when I get to this slide, I'll just pass it. What we do at PAR is we have since we use Zoom, and I already said again, not promoting, just saying that that's the platform we use. There's such thing as team chat in the Zoom that you can set up. We require everyone who is providing services through telehealth, and we ask all our providers to have the Zoom home screen with the team chat open. In fact, when we open our computers, it opens automatically. We have different teams set up. One of the teams that is set up is called clinical supervisors. So every single clinical supervisor at Operation PAR is on this chat. Anybody has access to post in this chat in the entire agency. So if a clinician was on a telebehavioral health session and started to recognize that this person was needing to be Baker Act, they can put in the chat, I'm in a session, 911 situation, I need someone, this could be a Baker Act. We can then either have, and literally we've had this tested, and anytime there's been an emergency and someone's posted in there, within less than a minute, somebody is responding saying, I'm here. Do you want me to come into the session? Do you want me to guide you through the session? What would you like to have happen? So what typically, there's been different ways. I've been called in on two sessions where there has been a medical emergency. The person thought they were having a heart attack, and we needed to call emergency services. So I actually Zoomed. They invited me into the client, get permission for me to come into the Zoom session. So I was in the Zoom session. I ended up calling 911 while the clinician was able to continue speaking with the client. We got the emergency services there. We stayed in contact with them and on Zoom until they took her to the hospital. So I think it's very important to how you set up your safety mechanisms within that. If someone was to be Baker acted, they would put in the chart. Again, we've had this happen many times. Supervisor would either come in on the session or communicate with the person through chat. Would you like me to call? In that situation, we're not going to have a licensed person be able to fill out the paperwork necessarily, because we wouldn't be able to hand the paperwork to the officers as they arrive to transport. So we would call, we would call the non-emergency number for the Sheriff's Department, tell them that we have a Baker Act, and give them all the information that we have, stay on this. So this way the clinician can stay on with the client and continue to communicate with them as we go through the process until the officers arrive and we can walk them through it. That's been the best way for us. It's been highly effective. It's been highly safe. That's how we handle it. So depending on, Rochelle, the platform that you use, setting up some way that people can contact people immediately, given that we have this these chat rooms open up when people turn on their computer, it's very helpful. And again, I tell people, if you're a clinical supervisor, while you are on, this needs to be open. It's on, our clinical supervisors have PAR cell phones as well, so they can access the Zoom chat on their PAR cell as well. So we've really been able to handle situations, because we may have people, again, if we're providing hybrid services, we may have the clinician being at home, the client at home, and we're at the office. But we can still communicate in a way in live time to be able to deal with those situations. So I like that. Most versatile, just saying. The one thing I did notice, we use Zoom, like I said, but I was involved in you're welcome. I was involved in Teams the other day, presenting to a class at University of South Florida, and they had a cool feature where you could have your face right next to your screen, right next to your PowerPoint, and it was like kind of like you were on the news. It was pretty cool. I did like that. But anyway, whatever platform you use, you need to pay for it. You need to have a business associates agreement, and you need to make sure that you learn it and utilize it to its fullest, including things like if they have chat rooms and things like that. Very, very, very helpful. So we have to be the ones who are modeling and are talking about and training how to use telehealth, and modeling for our clients as well. So again, you lose some connection through touch and gesture. We must heighten our verbal engagement skills, active listening like nobody's business, use of empathetic statements. Again, I saw somebody was looking for MI training. MI training is wonderful. Be more purposeful in the tempo of our speech and tone, because those are the most receptive senses to patients in the virtual environment. Really important to practice. That's why you have to practice these things. Just like when we were in school, I remember doing role plays for individual, family, group, getting commented on by my classmates, getting comments by my teachers, doing it at my field placement. Same things with telebehavioral health. I think there were so many people out there at the beginning were just like, just put them on there. They already know how to do the services. Well, they do, but you have to do it in a different way, and you still need to have that practice. And I know I've said that a million times, but it is so true. Be on the lookout for disinhibition effect. Obviously, we know that that occurs. And if a clinical supervisor, check with supervisees regarding that. Ask them about it. Thank goodness the counselor that had the teenager that turned his phone around and showed it to her friends ran down the hall and told us about it. But because we need to ask, have people been doing this? Do you notice that they are, like you said, drinking something potentially? We don't know if it could be alcohol or not. Or do they log on and they're in their pajamas, or they have just a bathing suit on, or what's going on? Make sure you have those conversations and make sure they're addressing them. Obviously, when we're only seeing, we brought this up too, shoulder up. Words and body movement have to replace those behaviors that we usually do with reading someone's full body scan, understanding their body language. Developing a screen side manner. Wear solid clothes if you can. Now, I don't always follow this one. I did today, but of course I didn't put myself on camera, but I wore solid clothes today. But I think it makes a difference. It can be, when you have really heavy patterns against heavy patterns, it can sometimes look weird on camera. It can be distracting. We have to make sure that we don't have background noise in our environment, just as we ask our clients not to. Make sure your face is in the middle of the screen and takes up, a good rule of thumb is 2/3. I see people on their head is super, super tiny. I can't even see them, or they have the camera way up where it's looking down on them, or way down and it's looking up their nose. Make sure that you have it, stay seated in your area, and make sure do not swing your chair. Do not get up and paste. Those kind of things are important. It's very distracting. Fidgeting, tapping, any of that stuff. I had someone on, it was a meeting, but it was through Zoom, and the person that was running the meeting kept moving the microphone, and dear Lord, on our end, it was so super, super loud. It was so distracting for me. I was like, oh my gosh. And then she kept moving her papers right next to the microphone, which I hope I'm not doing today, but she was doing it. It was so loud. So making sure that you have all those things. Jewelry. I took off my bracelet today because I had on a bracelet, and I know every time I put my hand down toward the desk, it was clinking really loud. So just being aware of those things. It sounds silly, but these are the things we have to do. Ice or gum chewing, background noise. This was put on by a group that I worked with, and they were saying they didn't want a video camera showing people and demand that people have their camera on. We do require that they have their camera on in our facility. We have a discussion with them about it. If they feel uncomfortable about it, there's ways to get around it where it doesn't have to be that their face is right on it. You can show them and walk them through how they can make their screen tiny and yours big, so they're not staring at themselves or having confusion that way. That's important as well. So with these hybrid relationships, we talked about across multiple technology platforms and settings, have an appreciation for the strengths, limitations, and adaptations needed for technology, and being able to have those discussions with individuals. Becoming informed about adopted emerging technologies. I think it's really important. And we are very, very fortunate here that we have both a wonderful IT department, as well as having folks, myself and others, that are really looking for those opportunities, those ways to bring more services to us and to the people we serve. So look at those emerging technologies. There's, all sorts of patient portals, there's apps, there's web-assisted therapy, there's value-based care platforms. There's all sorts of things going on out there, and look to see what you can utilize. Google it, look it up. When you go to conferences, there's representations from all of those entities there, have conversations, look at it, ask them to show it to you, demo it, set up a demo, all those things. So you can see what can work best with your agency and the folks you serve. Also, how you figure it in cost-wise, if this is something that you need to look at budgeting for next year or in 2 years, or, figuring out how you do that. Very important. So, it's the little things. Making sure there's privacy, professional and warm. Use it. So again, this is one we put on here. It's if you use more than one office site, when we have people participate or provide services from their home, we have them log on with somebody, show their space, practice some things. And we actually, I'll show you later, we have it where people are approved to work from home, that we sign, and it actually goes in their HR file that we've seen their space, we've seen that they're able to manage their space. Because the last thing you want is people to say, like, yeah, I can work from home, it's no problem. And they're sitting where their roommate's walking behind them, or, dogs barking constantly, or whatever it is. We really have to do that. So that's an important part of making sure that we have thoroughly evaluated what they do. So ethic reminders, follow the requirements for ethical conduct from your profession's code of ethics. You can Google those, look them up. Assess for client appropriateness that we discussed about. Not every client may be appropriate to receive services in this way. And that's okay. They may get to the point of being able to do it or not, but you need to have that, assess for that. Unless you're in an extremely rural area, this is the only way to provide services. Then you need to really look at, is it more beneficial to provide the services than not to provide the services? And really, how do you set up the best safety techniques you can? Always make sure that you and your folks are practicing within your scope of practice when you're doing this, just as you would within your office. document all services as you would face-to-face. We actually, what I mean by that is you just document the services. But in our electronic health record, we have it noted if you provide a session through telebehavioral health or if it was face-to-face. That way we can keep some data and how we bill. So that's really good. Make sure your malpractice insurance or your agency's malpractice insurance covers telebehavioral health. They pretty much do now because it's common for people to do that. But in the beginning, it was not common. And we really had to remind people to make sure that they, because some people had to get an add-on. Some people, it was an add-on to their policy. So really make sure that you do that. And if you're a substance use provider, make sure you're following CFR 42 Part 2, which is more restrictive than HIPAA in your virtual environment as well. Make sure you have an informed consent that includes nature of treatment, risk, benefits, alternatives, opportunities for questions from your client. Again, liability insurance and the limited services. And you can look at these two resources here to do that. I've seen a world-renowned specialist do webinars. I know, Kelly. Kelly, I was on with someone that I highly, highly respect who was doing, now it wasn't a full webinar. It was really a training session with, it was probably 8 of us that gathered. And she was in her room with an unmade bed behind her. And I was just flabbergasted that this is someone that has been working in telebehavioral health for quite some time, advocating all this. And this is what she has us looking at. No one said anything. I think we all felt weird about it, but we probably should have. But it's very important. You don't want your space to look like chaos and craziness. Even for meetings, like I'm very, the people that work for me, I'm very, very clear on that. If you maybe even need to put up a virtual background, or if you need to blur your current background, do that. I think it's one of those things that sometimes you have to explain if you're working with clients. We had a client that the person was working from home. Their background wasn't chaotic. It was just kind of boring and whatever. So she was trying different things. And one of the things that she had it on, I think it was like a slight blur. I don't remember, but the way the lighting was, it started to show some shadows, and the client got very paranoid and was saying, I believe there's someone in your space. I'm seeing a shadow of like someone's there. And she's like, there's nobody here, and turn around her camera. And the whole session turned into this person being concerned. And at that point I said, it would probably have been better just to have your camera fully on and try some other lighting, find somewhere else in your house. You need to figure something out. And I was like, who was your supervisor that approved that space? Because clearly there's some issues there. But you have to be careful of that, because with some clients, especially we have clients that may have some paranoia or be highly anxious, that would be concerning for them if they saw things in your background. So really, really, really important. All right, some of the lessons that we've learned, and I know we're running close to the end, so I'll fly through these. I already said that we have our employees as they start work their first 90 days in office, and they can provide telebehavioral health from the office, but when they are able to work from home, it's after the 90 days where they can do that. Just turn the desk or laptop around to a blank wall. Absolutely. Yeah, absolutely. It is helpful to do that. And people need to recognize that and be able to adjust to that. Absolutely. And we have clients come in for their first admission session just so we can have them sign things, verify who they are, do their first drug screen, all of that. I will say, in our hybrid service delivery, we did develop with one of our doctors a way to do drug screens virtually. We do oral ones. They're all observed on screen. They're sent one at a time, ahead of time, randomly. And we have a whole process and protocol for watching folks do that on screen, including sealing it, putting it back in the bag, mailing it back to us, all those things. And we do that again with discussion with supervisors of who would be okay to do this process with and who we really need to have come in for drug screens. So that's something that this is what I was talking about, that we have set up for if people are going to work from home for telehealth, but they have to have approval and they have to demonstrate their equipment, they can deliver the space, blah, 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 their home is approved. We have YouTube video instructions that I created walking through people how to set up your background, how to set up your lighting, what is appropriate, what is not appropriate, so on and so forth. We also require people to go through, and I'll be honest, through COVID, we didn't do all of this as intense as we should, but now coming out of it and providing hybrid services, we are. Telebehavioral health training, we require a minimum of 2 hours before you start providing telehealth trainings. And we have our own 2-hour training. We will accept other trainings. We just work with people. And then I put on the supervisors that it needs to be part of their supervision discussions, how they're doing within telebehavioral health. So safety checklist, we developed 3 of them. We have your completing telebehavioral health from home, if you are the provider and you are completing it from home, or we have our checklist from if you are doing telebehavioral health from your office. And we also have a group safety checklist. And what I would say for this is we ask people to go through this every single time. Our checklists are a front and back of a regular page printed out. I ask people to keep it by their desk at all times and make sure they cover each area. A tip I will give is basically you're collecting, you know, a video check, an audio check, you're collecting safety information, you're going over privacy and in case of emergency. But our checklist is a little bit more expensive than that. But those are the basics on there. And a tip that was given to us is people that were working from home, we didn't want them writing down their in case of emergency information or their address and then having this pieces of paper all over their house or whatnot. So we asked people to buy small, or we bought them for them, small whiteboards, the little ones that are about the size of a page. So that when they're almost when they can say, hey, what address are you at today? And you can quickly write it down on the dry erase board. What is the number you want me to call if we get disconnected? Who's your in case of emergency? Blah, blah, blah. And then you have it on the dry erase board for the session right in front of you in case something happens. And then when the session ends, you can erase it and we're all good. So that's one of the tips that we did with folks, which was really helpful. This is what our checklist looks like. If anyone is interested in this checklist at the end, my email will be on here. You can send me an email and I will be happy to share any of the or all of the checklists that we've created. So again, some of the reasons that it's not okay to see people. We don't allow people to see people that are actively suicidal or homicidal. That needs to be face-to-face. Maybe a psychosis, they're under the influence or intoxicated, they have an active thought disorder, they're not stabilized on medication, or they've been real inconsistent with attendance or a lot of cancelizations. We ask people then to come into the office for a period of time. It doesn't mean that they won't go back to being seen telebehavioral health, but we really want safety first at all times. Again, I told you about our Zoom chat rooms. I went into that earlier of how we do that. And so I know some of you were talking about, you know, getting started. There is costs to get starting telebehavioral health within your agency because you will need, you know, computers, devices, you may need laptops, cameras, lighting, different lighting may be part of it. So costing out all of that, the cost of the platform itself. We have some of our folks on the paid platform, and then we have people that are on pro accounts, or there's like there are different levels of accounts with platforms often. And we have some people that have to have the higher level because in order for me to run a meeting with 50 or more people for longer than 45 minutes, I need a pro account. So just making sure when you are looking at platforms that you look at what you can do with the various levels, and maybe in your organization, how many of each level you may need or may not need. Again, making sure it's HIPAA compliance, meets 42, and then you get that business associate agreement. Extremely, extremely important. With the hybrid policy, I think some of the workforce issues like I talked about was making sure people are able to fully and completely switch their attention and be able to remember what to do and how to do each session. And again, there's more lift on the side of telebehavioral health, more things you have to do ahead of time, be prepared for, walk through, all of that. Adequate compensation, social responsibility and cultural competency, and office and home. And again, I would add that with all of this, since we're coming out of COVID, and again, I think COVID was such a parallel process for all of us to understand how to provide good self-care, how to truly do it. We as providers, we as practitioners sometimes, you know, teach our clients, even expect our clients to do homework and practice and do these things and make changes. And if we ourselves are not doing it, if we ourselves are not asking as supervisors how people are taking care of themselves, because telebehavioral health, again, like I said, can be very draining. It can feel more draining. And then if you have on top of that, feeling isolated, not connected with coworkers or whatever it is, you're going to experience more of it. So it's really, 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 really important that you have conversations about that. You check that in, you have policies, you have procedures about it. Very, very, very important. And I just have, this is one of the offices of one of our therapists, and you see that our therapists, they're allowed to have more than one screen. It's really helpful. I find it, I have 3 screens myself, and I have the larger screens. It's really helpful, especially when you do have to share things on screen, where you can have things that you can look at while you're working with someone in telebehavioral health. But that's, again, not necessary. It's just a added convenience, and it's really helpful. And you can see the computer is facing away from the window. When you have the windows behind you, it often makes shadows, or it turns you where you can't make out your features, and it's very dark. So you got to make sure that things are, this is a standing desk. Some people like those too, more than the sitting desk. So making sure that they have a comfortable space, because again, it can feel very intense, the behavioral telehealth sessions. So group is a whole nother ball game, right? Group is difficult for people to learn how to do effectively face-to-face, and online it brings so many other challenges. And what I want to share with group, and the groups we do, everybody is in. I do recommend the double monitor. You're allowed to have things open that you can open. Now you have to become skilled. These are things you have to practice, right? But if you have a double monitor, you can open on one side the EHR and have pulled up the client's file, and being able to look at it and make sure it's all good before you share it with your client. If you're on a single screen, you can't do that as well. It's a little more clunky. So that's why I recommend it. So with groups, this is some data on it, but we have a Zoom group counseling agreement, again, laying out our group rules. We develop a group safe word. If somebody has somebody enter the space that may jeopardize confidentiality, we have the safe word, which would mean that everybody does not talk anymore, that we stop talking and we move on. We have usually, depending on the size of the group, but most often 2 facilitators for group counseling. Because there may be a situation where you have to take somebody into a breakout room or something and have a conversation if they're having difficulties, whether it be that they're having technology difficulties, or they're having some other kind of behavioral difficulties or meltdowns or emotional dysregulation. You may need to take them into a breakout room and maybe return with them later. And if you have 2 facilitators, you can do that. If you have 1, it becomes more complicated. We sometimes do this where we call ahead with some of our smaller grades. When they're larger grades, we have people most often tell us where they are if they're at somewhere different than what they have on their registration with us. And we have them put in the chat. That's why we also have 2 facilitators. So one can write down where people are and the other one can facilitate the group. You have to be careful though, because you want to make sure that people only communicate directly in the chat to the other facilitator and not to everyone, or they're putting your address and everything else to everyone in the group. So it is a little challenging that way, and that's why we were calling ahead. But for extremely large groups, that's difficult to do. So that's kind of how we run our groups. And you need champions. You need champions of telebehavioral health, and you need champions of convincing people and keeping the spirit going about providing hybrid service delivery. Because if you don't have the people that are doing that, you're going to have people that fall back to, well, it's not as good. It's easier to do individual. I'd rather do individual, those kind of things. Maybe you don't, but that's kind of what other providers have experienced. I know we've had some of that here ourselves, but if you have that those champions and those cheerleaders that can advocate and be out there and talk it up, really, 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 really helpful. And so if therapists choose not to participate in this emerging field where we're providing hybrid services, other people will pick it up. And who do we want doing this kind of work? We want to make sure that we have peer support specialists and certified peers and licensed therapists and master level therapists and bachelor level therapists and people being supervised providing this work. But even if therapists decide not to offer telehealth services, or you as an agency decide that's not for you, you still need to be aware of it and be able to answer questions for clients and be able to know what's going on and have people to refer to if that's what they would like to have happen, right? So, in summary, it's equivalent to in-person care. It's the same but different. We said that many times. Research based on mental health services is extensive. Research based on SUD treatment is growing. Patients express satisfaction with it. There's national guidelines. Clinicians may be initially reluctant. Training and practice over and over and over and over and over and over must happen. And telehealth hips, status, keep up with laws. And let's see, we got, do you recommend, let's see, can registered interns provide tele? I must have a big license. So yes, registered interns can, as long as they're under a licensed supervision. And but I would encourage you, if you go into the profession's ethical guidelines regarding telebehavioral health, I know social work has like a book on it. Others do have it addressed in their guidelines, are their profession's rules on telebehavioral health. So go look at that. But yes, if they're under the supervision of a licensed person, they can. Do you feel Zoom is secure and doxing me? Zoom started out, there was, someone said Zoom, double explanation. There was some stuff during COVID when people were on Zoom that people got hacked into and all that stuff. All that has been taken care of as far as we know. We personally have not experienced any problems with Zoom security, but I would encourage you for all platforms to go on their websites, have demos set up, ask questions. And make sure you can find regarding interns. There you go. Thank you. Florida Department of Health Board website. Perfect. All right. And I believe that is it. Thank you all so very much. I love talking about this and I appreciate the time and I really appreciate y'all chatting and having conversations with me. Thank you so much.
That was absolutely perfect timing, Sandnes. Thank you so much for all the work that you put into this webinar. It's really was a great webinar and very informative. I think everybody got a lot from this webinar. So thank you so much. And I hope you can see in the chat that everybody really appreciated your time and effort. Before we conclude today's webinar, I am going to go over a couple housekeeping items. We have included Sandnes' contact information so that you may contact her with any further questions. Please see the chat panel for a link to today's evaluation. If you want to receive CE credits or a statement of credit for this event, you must complete the evaluation. There are instructions with how to complete the evaluation with the link to the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker, you needed to include a license number when you registered for this webinar. After you register or sign in, you'll be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have set up in your FATA profile, as this is the only way to connect your attendance with our system in your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. Please remember the evaluation will close midnight, Friday, April 28th. We do not email statements of credit. Instead, after we verify attendance, which could take up to 30 business days, a statement of credit will be generated as a journal entry within your profile. Remember, this could take up to 30 business days. Thank you so much for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Thank you all. Have a great rest of your day.